Hello, my name is Landry Fowler, and I'll be speaking on the pathology of a Baker's cyst. So what is a Baker's cyst? Also known as a popliteal cyst or a popliteal synovial cyst, it is swelling formed on the posterior aspect of the knee, known as the popliteal fossa, due to an increase of synovial fluid. They are most commonly associated with degenerative conditions of the knees. As mentioned previously, a Baker's cyst is caused by swelling in the knee. When pressure builds up, fluid squeezes into the back of the knee and lubricates the knee joint. A Baker's cyst commonly occurs with cartilage injuries, a tear in the meniscal cartilage of the knee arthritis primarily in older adults, rheumatoid arthritis, and/or other knee problems that cause knee swelling, and synovitis. Symptoms of Baker's cyst can include sharp pain, especially when bending or straightening the knee, stiffness and limited range of motion in the knee joint, a sensation of tightness or pressure behind the knee, and on occasions, if the cyst may rupture, it can cause sudden and severe pain, swelling, and redness in the calf area. So how can we play a role in diagnosing this pathology? Imaging plays a crucial role in diagnosing a Baker's cyst. Different modalities such as MRI, ultrasound, or even X-ray can aid in confirming the presence of a cyst, assessing the size, and determining any other underlying issues in the knee joint that may have contributed to its formation. As the primary modality of choice, MRI is considered to be the gold standard when evaluating a popliteal mass, due to its ability to use the axial plane to establish positive identification of the high signal intensity fluid-filled neck of the cyst that connects the cyst to the joint space. According to Medscape, MRI allows assessment of the entire spectrum of related disorders, such as meniscal tears, chondral defects, loose bodies, synovitis, osteoarthritis, and ligament tears. It typically shows up as a homogeneous, well-defined rounded or oval-shaped area with high signal intensity on T2 weighted images, indicating the presence of fluid. In addition to visualizing the cyst itself, MRI can also provide information about the surrounding structures, such as the knee joint and the tissues in the popliteal fossa. It can help determine the size and location of the cyst, as well as identify any associated inflammation or injury in the knee joint. Overall, MRI is a valuable tool for diagnosing and assessing Baker's cyst due to its ability to provide detailed, multidimensional images of the affected area. As for the additional modalities, ultrasound is able to determine if a popliteal mass is a pure cystic structure or a solid mass. It will typically appear as a well-defined fluid-filled sac located behind the knee joint. It often looks like a round or oval-shaped structure with clear boundaries. Ultrasound, like MRI, can show any associated inflammation or thickening of the tissue surrounding the cyst. As for conventional radiographic images, a Baker's cyst will appear as a soft tissue mass. Occasionally, a Baker's cyst is suggested by the presence of multiple calcified loose bodies in the cyst. A non-infected cyst with gas-like lucencies may occur along with diabetes mellitus and rheumatoid arthritis. The images below are from my primary modality of MRI. Synovial joint fluid can be seen in both images indicated by the white arrows with the help of Prohance that had been intravenously administered. In the axial T1 weighted image, the fat saturation reveals the formation of a Baker's cyst connected to the knee joint by the way of a narrow neck between the tendons of the medial head of the gastrocnemius and symbraniosus muscles, indicated by the red arrow. Treatment options for Baker's cyst include therapy such as going to physical therapy and gentle exercises or following the RICE method, which stands for rest, ice, compression, and elevation. For rest, you should stop the physical activity that caused the injury to avoid making it worse. Ice, you can apply an ice pack or cold compress for 10 to 15 minutes every hour after the first day of your injury. After 1 day, you can apply every 3 to 4 hours, but do not apply the ice directly to your skin to avoid burns. Compression helps reduce blood flow to your injured knee and reduces swelling. You can wear compression bandages or compression pants, whatever helps keep pressure on your knee. And elevation. If possible, try to lift your knee and lower leg above the level of your heart. You can do this by supporting your leg with pillows, blankets, or cushions. Medication. Any non-prescription medications such as pain relievers, being acetaminophen such as Tylenol, ibuprofen, meaning like Advil, or naproxen sodium such as Aleve, can help aid in reducing the swelling. If pain worsens, steroid medication injections such as cortisone can be done. Surgery or other methods include draining or aspiration of the fluid in the cyst or complete removal of the cyst. However, surgery is pretty much rare when it comes to this pathology. It's most likely not needed, but if it is an option. Care and prognosis of Baker's cyst is pretty simple since symptoms will come and go, and long-term disability is very rare. Still, like mentioned earlier, if needed and the pain worsens, surgery is also an option. Listed below are great articles about this pathology that I used for my resources. Thank you so much.